So our next talk is Dr. P S Vali, who is going to talk on renal transplantation in a patient with multiple myeloma.
I think one comment till they fix up the technicalities, one comment from the audience or from the chairpersons.
Dr. Vali is a consultant nephrologist at Asian Institute of Nephrology Urology, Hyderabad. Formerly, he was associate professor at Usmania Medical College and General Hospital. He'll be speaking on renal transplantation patient with myeloma.
Good afternoon, respected teachers, seniors, chairpersons, and my dear friends. The concept of contemplating renal transplantation in multiple myeloma is a much debated topic, and in the literature, to the best of my knowledge, less than 70 cases have been reported. So, in this lecture, I am going to talk about these 8 key points in a bite-sized format. The first question is, why are we discussing about this? We are discussing about this because multiple myeloma is the most common non-urological malignancy leading to ESRD. Renal impairment is presentation is noted in 25%, whereas 50% of individuals over a period of time can develop renal impairment at any time. As we all know, the most common presentation is cask nephropathy, followed by MIDD, followed by renal amyloidosis. To note, the survival was very dismal way back in 1990s with 29 months, whereas in the year of 2019 or current era, the survival has exceeded more than 8 years or to 10 years. The second question is, what does the history taught us? History was not kind to us in this regard, and majority of the case reports reported disencouraging outcomes. In this paper published in 2004, in this study, wherein transplantation results in light chain deposition disease was studied, 7 out of 7 patients demonstrated histological recurrence, whereas 5 out of 7 patients lost their graft within a span of 33 months. The same results were replicated in other case reports, wherein the transplant was contemplated before the year 2006. Therefore, basing on this report, the conclusion was that it is better not to contemplate kidney transplantation in myeloma patients. Therefore, are we justified in contemplating kidney transplantation in myeloma in this era? To answer this question, we should know 2 data sets. The first data set is, what was the survival before 2010? In those patients of ESRD with myeloma, the survival was hardly 9 months, whereas the mortality used to be 2.8-fold higher than other non-myeloma patients. And the most common cause of death was disease progression or relapse. Whereas the trends started changing after 2006. It is not because of the fact that 2006 was the year where I entered general medicine or nephrology, but it is because of a robust fact that from 2004 onwards, bortezomib has been introduced. Along with it, 11 other promising and revolutionary time-tested drugs were reintroduced. So these are the various drugs which changed the face of myeloma treatment and therefore has shown enormous improvement in the lives of multiple myeloma patients. Therefore, 11 new agents. Now the standard of care is 2. First of all, we should try to decrease the clonal proliferation by using robust induction agents with the newer agents. In those patients who are fit enough, who survive the first phase, are the candidates to go for autologous stem cell transplantation. Therefore, the most common induction regimen is the triple drug regimen, known as VRD regimen, popularly all across the globe, consisting of bortezomib, lenalidomide, and then dexamethasone. And in those patients who are fit, that means those who achieve complete remission or VGR, very good partial response, they can be contemplated for autologous stem cell transplantation. Therefore, on this background, we need to examine whether current data is encouraging or not. The current data is very sparse, but still it is encouraging. In this paper, which has been published from my group, wherein 11 patients undergoing 12 transplantation has been examined, it has demonstrated pretty good results, stating that the 1-year survival was 82% and 5-year survival was 61%. Moreover, the graft survival was 83% within 1 year and 66% by the end of 5 years. Now, with this encouraging data, let us know who are the eligible candidates. Before thinking about eligibility, we need to rule out those people who are not candidates. There are patients with high LDH, that means more than 2.2 times than the baseline, extramedullary disease, poor performance status, or those patients who continue to have persistent disease despite undergoing stem cell transplant. The second question we need to ask before contemplating the decision of transplantation is, did the patient undergo both induction and autologous stem cell transplantation? The patients who undergo induction only can never be contemplated. Those patients who undergo both induction and achieve decent hematological remission after stem cell transplantation need to be contemplated. But that is not the end. After undergoing this second step also, in consultation with our oncology colleagues, we should sit back and ask ourselves whether the patient belongs to high-risk strata or standard risk strata. Of course, it is based on few complex cytological issues, especially by FISH studies. And more important thing is the concept of looking at MRD, the minimal residual disease. It is nothing but looking for the minimal quantity of residual disease in those patients of myeloma who were declared to achieve complete remission. That means we are going to look at the bottomest strata of a submerged iceberg. Therefore, this minimal residual disease can be known with the help of the recent gadgets of next generation sequencing. And the patients who continue to have MRD, the minimal residual disease, are the candidates who are going to show relapse within a span of next 2.5 years. Therefore, in this category of patients, probably we should wait and watch. Therefore, the MRD to the tune of 10 to the power of 5 should be our target. It is desirable, whereas 10 to the power of -6 is preferable. Now, this is the most important conceptual tool, which states that those patients of standard risk with MRD negative, they are the candidates who are going to do extremely well. Whereas high-risk individuals with MRD negative, still we can contemplate. Standard risk patients who fail to achieve MRD, still you can contemplate. Rather, the dynamites are the high-risk patients with MRD, they are the candidates who are going to recur within a span of 6 months after transplantation because of the profound immunosuppression which we are going to give. Then how much time to wait? In case of the first strata, that means standard risk patients with MRD negative, we need to wait for 6 months. Whereas the second strata, that means high risk with MRD negative, or standard risk with MRD positive, we need to wait for 12 months. Whereas the first strata, probably they are never the candidates for transplantation, unfortunately. Now the question is, how do you do maintenance of post-transplant patients in this scenario? We need to offer maintenance of twofold. The first fold is for the allograft. The second is fold for myeloma, because myeloma is such a cancer. In contrast to other solid cell tumors, even though the patient has been in complete remission for 20 years, he can show or demonstrate relapse on 21st year. Therefore, despite achieving the deepest possible hematological responses, multiple myeloma patients are going to relapse, and that is the template of myeloma patients. Therefore, they are the individuals who need to be on some form of maintenance. But only issue is we should avoid immunomodulated groups, because clear-cut case reports have been demonstrated that the drug lenalidomide has been established, has been associated with steroid-resistant and multi-drug-resistant rejections. Therefore, the best agent is bortezomib along with other proteasome inhibitors. The next question is, how do you monitor them post-transplant? We need to look at free light chain assay, and elcrophores is at least once in 3 months. And relapse is the most common, but we should not get feared with every relapse, because every relapse does not translate into graft loss. Infections are most anticipated, most feared, but surprisingly they are less common. And almost all the review articles quoted that probably there should be some amount of publication bias or lack of granularity of the data in coming to this inference. And cardiovascular complications are well known, along with drug toxicities. And then, how to move forward? What is the template? Template doesn't exist because it's a very rare scenario. However, the template takes the form of take-home message. The key takeaways are, myeloma is the most common non-neurological cancer leading to ESRD. Transplant done in olden era disappointing. Renal transplant is possible in the current era who undergo both induction therapy along with stem cell transplant. And current era's case reports, albeit limited, are very encouraging. Those who are eligible are those patients who undergo both induction chemo, stem cell transplant, along with MRD negative status. And myeloma needs maintenance of twofold, one for allograft, one for myeloma. And second thing is, infections of post-transplant are not common, but relapse of myeloma is common, and every relapse doesn't translate into graft loss. Of course, positive attitude and negative awareness, this applies to every facet of life, including this scenario. Thank you.
You you said minimal residual disease, but the literature also mentions about near complete remission or partial remission. So whether those patients can be taken for transplant?
Probably, I think oncologists can answer this question very well, sir. But whatever literature I have reviewed, every paper has established that in the current era, we need to look at MRD. MRD is very much available even in India also. Probably because it looks much beyond complete remission.
No, you can ask one or two questions, yeah.
Any more questions?
Yeah, I think Dr. Gopal Krishnan is
Dr.
around.
Gopal
Yeah,
Krishnan
he's also here.
actually,
Yeah.
We probably did not invite questions from, you can actually question Dr. Gopal Krishnan, sir. No problem.
We have a patient who has membranous nephropathy on biopsy, PLA2R negative, and I can call it MID. Yeah. So how many, there is no clone seen, and it's membranous nephropathy
Exactly.
without any PLA2R positive.
No, it's not membranous.
It is membranous, sir.
You have a patient.
We have a patient.
Membranous nephropathy?
Is presented as nephrotic syndrome.
Okay.
Over time, RPGA, I mean the rapidly progressive renal failure, creatinine went from 2 to 4. And elderly, 55-year-old. Sir, there's no clone seen. So how do you manage this patient?
But immunofluorescence shows restriction.
Yes, sorry. It shows restriction, kappa.
So okay. So almost our case scenario is almost like that only.
There is no proliferations like we are saying PGA.
Yeah, exactly. The light microscopy, the pathology of MGRS varies. I mean, it can be a proliferative pathology, mesangial proliferative pathology, or it can be membranoproliferative pathology. Very rarely atypical membranous nephropathy as well. It is very rarely. And also there is one more entity called membranous nephropathy, membranous-like nephropathy with masked immune deposits.
Yes.
So we have to subject the tissue specimen for pronase digestion, and you pick up this thing also. And there is a controversy whether to call it that, to be incorporated, that entity has to be incorporated as MGRS or it is a different entity. But almost the treatment guidelines are the same.
So, Dr. Baumix.
Yeah, I'll just mention here that we had done one case 6 years back, multiple myeloma, and that time she was, I think, around 35 years old. And she has now completed 6 years. And during the 6 years of multiple myeloma, following your hematologous stem cell transplant, she's completed 6 years, did not have any issues regarding renal function or any infection or relapse of the disease. Very recently, she had one pneumonitis, went outside, and the physician prescribed Claribate for 3 weeks. And then she came to the creatinine of 1.9. And as you can expect, that the CNI levels are very high. And after that was sorted out, the creatinine has come back to 1. So that's the only one case that, at least we have done, and it has been published.
Simultaneous or is it sequential?
No. We waited for 2 years.
He was into complete remission as far as myeloma
We
is
went into
concerned.
MRD. I'm sorry, MRD was not done,
Okay.
but it was in complete remission, and we waited for 2 years just to be sure. After 2 years, we had done the transplant. Post-renal transplant is now another 6 years now.
Okay.
So congratulations, sir. Your patient is one among those.
It's so difficult in our country to get a myeloma patient getting into renal
Yeah, but
transplantation.
see, after that,
he
I'm
has to
not-
come out from that particular department to our department totally. It's not so easy.
It's not easy, and till then we're not done
So many
anymore,
obstacles
So we've done only one actually so far. And just to complete what they were discussing, sir showed beautifully, all the lesions of MGRS. Membranous is not mentioned in that.
Yes.
In fact, it's very uncommon, but recently we also had a similar case of membranous with kappa restrictions. So that also very rarely can present as MGRS. Thank you.
One practical question about amyloidosis secondary, which nowadays we have patients on long-lasting dialysis. So with high microglobulin, beta-2 microglobulin, many patients. So any change of dialyzer or any experience and what type of dialysis they should be taken?
Okay, thank you for that. And thank you, chairpersons and speakers.